Imagine being the fastest swimmer in the world. You're leading the pack at the French championships, the crowd is roaring, and you are just, entirely in your element.
Yeah, everything's going perfectly.
Right. And then in a fraction of a second, you pull up. Like you've literally been shot from the stands.
It's such a shocking visual.
It really is. So you slow down, you finish dead last in your heat, and you bow out of the finals. And if you've glanced at the sports news today, which is June 29, 2026, you know that's exactly what just happened to French swimming phenom Léon Marchand.
The entire sports world is buzzing right now.
Oh, completely. And the initial headlines are all saying the exact same thing, right?
Yeah.
Adductor injury. But today, we're going to look at why that simple headline might actually be hiding a massive medical misdiagnosis, and it's playing out in real time.
It is a phenomenal real-time case study because, well, when you push the human body to the absolute bleeding edge of elite performance, diagnostic certainty just kind of goes out the window.
Yeah, the textbook answers don't always apply.
Exactly. So the sources we are digging into today include a really detailed medical breakdown from experts like Dr. Delong, alongside data from cutting-edge sports tech companies like Kinexa.
Which is fascinating stuff.
It really is. And they suggest we are looking at a biomechanical mystery here that goes far, far deeper than just a pulled groin muscle.
So welcome to today's deep dive. We are taking you on a medical sleuthing journey to uncover the hidden physics of elite swimming, piece together a highly unusual injury, and see how artificial intelligence is stepping in to fundamentally change how we put broken athletes back together.
It's quite the mission.
Let's get into it. To figure out why Marchand suddenly stopped in the water today, we have to start by interrogating the usual suspect. I mean, every trackside reporter is blaming the adductors. So functionally, what are we actually talking about when we say adductor?
Well, the common misconception is that the adductor is just, one big inner thigh muscle.
Sure.
But in reality, it's this complex web of 5 distinct muscles. They span all the way from your pelvis down the inside of your femur.
Okay, so it's not just a single rubber band.
No, not at all. Think of them more like a heavy-duty suspension system. Their primary job is adduction, which means bringing your legs together toward your center.
Makes sense.
But functionally, they are doing so much more than that. They operate in a really highly synchronized kinetic chain with your glutes and your quadriceps to stabilize your entire pelvic bowl.
So whenever an athlete accelerates or plants their foot or shifts direction...
That suspension system is firing to keep their core anchored.
Exactly.
Okay, so they are the anchor point. And when you take that anchor and force it to perform the breaststroke, you are essentially asking for a mechanical failure. I mean, the sources detail just how brutal the breaststroke frog kick is on this specific web of muscles.
The physics of the frog kick really do create a perfect storm of stress because water is roughly 800 times denser than air.
Wow.
Yeah. So when a swimmer kicks, they aren't just moving their legs around, they are pushing against a massive, unyielding wall of resistance.
The cycle goes like this. The swimmer draws their heels up, which is flexion. Then they spread their knees wide and rotate their feet outward.
So that's the abduction and external rotation.
Spot on.
Yeah.
And that stretches the adductor web to its absolute maximum length. Then comes the propulsion phase, which is this violent, explosive extension and squeezing of the legs back together to shoot forward.
So picture a massive mechanical engine. Your adductors are the main pistons. During that explosive propulsion phase, when you snap your legs together against the heavy drag of the water, those pistons are taking the absolute maximum load possible.
Yeah, it's immense force.
You stretch them wide and then forcefully slam them shut. And you do that over and over and over again for thousands of meters a day.
And that repetition is the key factor here. Exactly. They are slow-building, insidious wear and tear issues. We often see insertional tendinopathy, which is basically microscopic fraying where the tendon anchors to the pubic bone.
Ouch.
Yeah, or we see swimmer's pubalgia, which is a deep creeping inflammation of the pubic symphysis joint itself.
So it's not a sudden snap usually.
No. Usually a swimmer feels a dull ache during warm-ups. It progressively worsens over a season, and eventually the chronic pain just forces them to stop.
But the way Marchand dropped his speed today wasn't a slow fade.
Not at all.
It was an acute, sudden failure. If breaststroke injuries are historically these slow, wear and tear chronic issues over a period of months, why did he pull up so violently today?
And that specific contradiction is the anomaly that kicks off our whole medical investigation.
The suddenness.
Yes, the suddenness of his failure completely defies the standard chronic overload profile of a breaststroke adductor injury. To find out why something snaps so suddenly, we have to look past the traditional frog kick and look at his secret weapon.
The ondulation submarine.
Yes, the deep underwater dolphin kick.
Right. He is famous for staying submerged off the turns and utilizing this incredibly powerful dolphin kick before coming to the surface.
And that technique introduces a completely different force vector to his pelvis.
How so?
Well, we just established that the standard frog kick forces the adductors into an explosive stretch followed by a violent squeeze, right?
Right.
The dolphin kick demands the exact opposite. During that underwater undulation, the swimmer must hold their legs tightly together while violently oscillating their pelvis to create a wave-like whip through the water.
Wait, so the adductors are no longer stretching and squeezing.
No.
They are locked tight.
They are performing a forced isometric contraction. They are holding a static, incredibly high-tension position. Meanwhile,
the core and pelvis are violently thrashing up and down.
yes, to generate that power.
Okay, imagine taking a thick phone book and holding it tightly between your two hands. You are squeezing it as hard as you can. Now, while still squeezing, try to aggressively slide your hands up and down in opposite directions.
Oh, wow.
That shearing, tearing friction right in the middle of the phone book, that is what his pubic joint and pelvic muscles are experiencing during the dolphin kick.
That sheer force analogy is spot on, and this is where the biomechanical nightmare really takes shape. He is essentially asking the exact same pelvic region to perform two completely opposing mechanical tasks at the highest level of human output.
That's crazy.
He pushes off the wall and executes these massive, shearing isometric locks. He surfaces and immediately transitions into the explosive stretch and slam of the frog kick.
It's a double stress
A
environment.
highly unusual double stress environment. He is subjecting his body to cyclic fatigue across two conflicting force vectors.
It's like asking those engine pistons we talked about to rapidly pump up and down at redline, and then a second later asking them to freeze perfectly still while the engine block vigorously shakes around them.
Something has to give.
Right. Eventually, a mounting bracket is going to shear right off.
And that mounting bracket failure is exactly what Dr. Christophe Delong and the medical analysis point to. The sheer mechanical contradiction of his technique is why these sources suggest the global headlines blaming an adductor injury are likely entirely wrong.
We're watching a classic medical misdiagnosis unfold.
We really are.
Let's trace the diagnostic deduction from Dr. Delong's analysis. If the engine is shaking itself apart, but it's not the adductor pistons, we have to look elsewhere.
Right.
So the first hypothesis the medical breakdown explores is the iliopsoas, the primary hip flexor.
It is the most logical first alternative. I mean, the dolphin kick requires massive, rapid hip flexion to drive the chest down and the hips up.
Okay.
The psoas muscle is a thick, powerful rope that connects your lower spine to the top of your femur. It's the primary engine of that flexion. Given the sheer torque he generates underwater, a proximal lesion of the psoas makes perfect biomechanical sense.
For the listener, when we say proximal lesion, we are talking about a tear or injury located closer to the center of the body, like right where the muscle attaches to the spine or the deep pelvic bone, as opposed to down near the knee.
Correct. And an explosive tear at that upper anchor point would absolutely cause a swimmer to stop dead in the water.
But the sources rule it out based on the presentation on the pool deck today.
Yeah, the symptoms just don't align. An acute psoas injury typically presents with radiating pain deep in the anterior groin or straight down the front of the thigh.
But his was different.
Right, an adductor injury presents with sharp pain, specifically on the inner face of the thigh. Trackside reports and the visual of him clutching a very specific upper medial area of the groin, well, they don't perfectly match a psoas rupture.
So the adductor is out because the injury was too sudden,
Yeah,
and the psoas is out because the pain location doesn't fit.
exactly.
What is the actual culprit hidden in this biomechanical mess?
The analysis points to a highly rare, highly specific structural failure involving the rectus femoris, the dryo anterior.
Okay, the rectus femoris.
This is the large quadriceps muscle running straight down the middle of your thigh, but the injury isn't in the thigh itself.
Where is it?
It is a tear of its reflected head, or chefreflechi.
The reflected head. Where exactly is
Well,
that?
The rectus femoris actually has two tendon attachments at the top of the hip. The straight head attaches to the front of the pelvis, but the reflected head hooks deeply backward.
Backwards.
Yeah, attaching to a tiny ridge just above the hip socket called the supraacetabular groove. It is buried deep underneath layers of other muscle.
Why would that specific hidden tendon Snap today of all days.
Go back to the underwater dolphin kick. To generate that whip-like snap, Marchand executes an explosive hip extension, driving his legs backward while simultaneously keeping his knees extended.
Okay.
That specific violent combination of hip extension and knee extension puts maximum unyielding traction specifically on that reflected head buried deep in the hip.
And doing that over and over.
Right, because he repetitively executes this against the immense density of water, the tendon eventually undergoes an acute avulsion or tear. It just snaps like a dry twig.
Wow. That perfectly explains the sudden sniper-like failure we saw in the pool. But here's the major disconnect.
What's that?
If it's a deeply buried rectus femoris tear, how can every sports doctor and trackside reporter be so confident it's an adductor?
For that, you have to look at the anatomy of the human pelvis, specifically an area the sources refer to as the triangle of pathology.
Let's visualize this. Imagine the front of your pelvis,
Yeah.
right around the pubic bone, as the center point of a brutal three-way tug-of-war.
Keep that tug-of-war image in your mind, but remember that these ropes aren't pulling in straight, clean lines. They are wrapping and weaving around the bone.
Right.
Pulling straight up, you have the abdominal muscles. Pulling diagonally down and inward, you have the adductor web. And pulling straight down and forward, you have the rectus femoris.
They all converge into this incredibly tight microscopic junction at the pubic symphysis. It's basically a physiological traffic jam.
A traffic jam where all three muscle groups share overlapping chains of tension. Now, put yourself in the shoes of a trackside doctor.
Okay.
A swimmer pulls up in agony. You have no imaging equipment. You do a quick manual exam on a wet pool deck. You press on the groin. You ask the athlete to resist as you push their leg outward, and the athlete winces in sharp pain.
So what does the doctor think?
The doctor runs the mental math. Breaststroke swimmer plus sharp groin pain plus pain under manual resistance. The brain immediately defaults to the most common answer, which is an adductor strain.
Because 99 times out of 100, that mental math is perfectly correct. The doctor's just playing the statistical odds.
Exactly. And the physical symptoms are nearly identical to the naked eye. You have severe inguinal pain, a sharp stabbing sensation that halts movement, and tenderness in the crease of the hip.
It's indistinguishable.
Yeah, without advanced technology, a doctor's thumbs cannot differentiate between a frayed adductor tendon and a rare tear of the reflected head of the rectus femoris hidden way underneath it.
So to actually untangle that triangle of pathology and see what's broken, the sources note that standard x-rays or even basic ultrasounds are useless.
Completely useless.
You need a highly specific MRI protocol, specifically something called an ABER plus Dixon sequence.
Yes. This is where diagnostic medicine meets high-end photography. ABR stands for abduction and external rotation.
Okay, so a specific physical pose in the machine.
Right. Instead of lying flat in the MRI tube, the athlete's leg is positioned wide and rotated outward. This stretches that deep hip joint open, essentially pulling the curtains back to reveal the reflected head of the tendon.
And the Dixon sequence.
The Dixon sequence is a specialized imaging technique that separates water from fat in the image. In normal MRI, fat can show up bright white, which obscures everything around it.
That makes sense.
Dixon suppresses the signal from the fat, so the only thing that glows bright white on the scan is fluid. And where there is a fresh, acute tendon tear, there is a massive localized pooling of inflammatory fluid.
It essentially acts as a neon highlighter for hidden damage.
Exactly.
Only by stretching the joint open and suppressing the fat can a doctor actually see that the adductors are perfectly fine and the true damage is sitting a few centimeters deeper on the rectus femoris.
Yep.
But this brings up a terrifying reality for elite athletes. If you don't get that specific MRI and you get misdiagnosed with an adductor strain, your entire rehabilitation is going to be wrong.
It is a devastating domino effect. Even if they somehow get the diagnosis right, the standard medical literature cites a staggering 30% recurrence rate for these types of complex pelvic injuries.
30%. That is essentially a 1 in 3 chance that your career ends the exact same way a few months later.
It's terrible odds.
What does the standard old-school rehab actually look like for this?
Historically, it is an agonizingly slow protocol. It starts with 2 to 4 months of rest, anti-inflammatories, and the classic RICE method, rest, ice, compression, elevation.
Sure, at the basics.
And for a breaststroker, they are strictly forbidden from executing a frog kick in the water for months.
Which means they lose their entire competitive edge. They lose their feel for the water.
Exactly. While they are locked out of the pool, standard physical therapy leans entirely into lumbopelvic core strengthening. A staple of this is the Copenhagen adduction exercise.
Oh, if you've never seen the Copenhagen exercise, picture this. You are lying on your side on the floor. You place your top foot up on a bench or a chair. Then, using only the inner thigh of that top leg, you lift your entire lower body and bottom leg off the floor to meet the bench. You lower your hips down slowly and pull them back up.
It creates a massive eccentric and concentric load on the adductor web. The goal is to build bulletproof tissue tolerance in that inner thigh.
But
But there is a glaring flaw in this traditional approach. If you spend 4 months doing Copenhagen planks, heal the tendon, and send Léon Marchand back into the pool to do his exact same double stress technique, you haven't actually fixed the problem.
you just put a fresh tendon into a broken machine.
Exactly.
You replaced the broken mounting bracket, but you didn't fix the engine vibration that caused it to snap in the first place.
Which is exactly why that 30% recurrence rate exists. And this is where the sports world is experiencing a massive paradigm shift, led by experts like Dr. DeLong and technology platforms like Kinexa.
Let's talk about Kinexa because the sources point to this as the future. AI is a massive buzzword right now.
Oh, huge.
It's easy to say artificial intelligence will fix physical therapy, but I'm stuck here. An algorithm sitting on a server can't reach into a pool and manipulate a swimmer's hip joint. How does a digital model actually translate to real-world tendon healing?
Well, it doesn't heal the tendon directly. It corrects the neuromuscular blueprint that broke the tendon.
Oh, I see.
Historically, a physical therapist would stand on a pool deck with a clipboard, watch a swimmer, and subjectively say, your hips look a little low, try to tuck your pelvis.
It's guesswork.
Total guesswork. Kinexa eliminates the guesswork. They use high-speed, markerless motion capture cameras both above and below the water, combined with wearable biometric sensors.
So they are gathering millions of data points on exactly how the athlete moves in three-dimensional space.
Exactly. They take all that kinematic data and feed it into an AI algorithm that builds a complete digital twin of the athlete's skeletal and muscular system.
A digital twin.
Right. Using a physics engine, they calculate what's called inverse dynamics. The AI can calculate the exact mathematical torque down to the Newton meter that is being applied to the reflected head of the rectus femoris during the peak of that underwater dolphin kick.
It's mapping the internal invisible forces.
Yes. The AI identifies the microscopic motor control failures. It might find that during the third undulation off the wall, the athlete's gluteus medius fires 14 milliseconds too late.
14 milliseconds?
Yeah, which causes the pelvis to tilt by 2 degrees, which exponentially spikes the shear force on that specific tendon. You cannot see that with the naked eye.
So instead of just handing an athlete a generic printed sheet of stretches and telling them to do Copenhagen planks, the physical therapist is given a hyper-personalized map. The rehab isn't just about strengthening muscle. It's about reteaching the nervous system how to fire in a sequence that mathematically prevents the tendon from tearing again.
It is the shift from generic tissue recovery to hyper-personalized biomechanical correction. And while it is being pioneered at the Olympic level to solve complex misdiagnoses like Marchand's, the implications extend to everyday orthopedic medicine.
You might not be aiming for a gold medal in the 200-meter breaststroke. But if you blow out your knee pivoting in a weekend basketball game, or you develop chronic hip pain from running, the future of your physical therapy won't be a generic rubber band routine.
No, it won't.
The future involves clinical AI modeling your unique anatomical geometry, finding the exact mechanical flaw in your gait, and correcting your movement before you break yourself again.
It is a profound evolution. We are moving from reactive medicine, just treating the symptom, to truly predictive and corrective medicine.
Let's step back and look at the whole picture we've uncovered today. We started with a simple breaking sports headline. A swimmer drops out of a heat with groin pain.
Right.
But by digging into the mechanics, we've untangled a massive biomechanical mystery. We explored how the isometric lock of the dolphin kick, combined with the explosive slam of the frog kick, creates a mechanical contradiction that the human body just struggles to handle.
It's fascinating.
We navigated the triangle of pathology to see how a rare rectus femoris tendon tear can easily masquerade as a common adductor injury to anyone without a specialized ABE Dixon MRI. And finally, we looked at how Dr. DeLong and the technology of Kinexa are using AI digital twins to map invisible forces and rewrite flawed motor patterns.
It's a reminder that the surface narrative, especially in human physiology, rarely tells the whole story.
The human machine is infinitely complex. And I want to leave you with a final thought to ponder today. Building on this idea of AI and predictive movement data,
Okay.
if systems like Kinexa are mapping the exact torque limits of human tissue, we will soon reach a point where these systems are perfectly predictive. Imagine a 14-year-old swimming prodigy who naturally adopts Léon Marchand's devastatingly fast double-stress technique.
That's a very real possibility.
A team runs their biomechanics through the AI, and the data spits out a 100% mathematical certainty that if they continue using this technique, their pelvis will suffer a catastrophic structural failure by age 20. Do we reach a point where athletes are actually banned from using highly effective techniques?
Wow.
Not banned by the sports referees for breaking the rules of the game, but barred by their own personalized medical data. When the math proves a movement will eventually tear a young body apart, do we intervene and change their stroke to protect them? Or do we allow them to accept that physical cost and risk it all for the gold?
When technology allows us to perfectly predict the future wear and tear of the human body, deciding what to do with that knowledge is a really fascinating dilemma.
We all crave that clean, binary certainty. We want the simple X-ray that points to a jagged line and says, there's the problem. But when you push human performance to the absolute limits of biology, that simple X-ray machine is useless. The truth is hidden deep in the biomechanical muddy waters. Thanks for joining us on this deep dive.